Dr. Kripke, I've had the pleasure of talking to you over the telephone prior to this event, and was pleased to hear you talking about communication with patients who have developmental impairments and different mechanisms of communication, and how in understanding communication, which, by the way, is also a legal word, that is, effective communication or not providing effective communication is a means of discrimination against people with developmental and or mental and or intellectual impairments. But I would ask you, Dr. Kripke, if you can describe not just your practice of treating individuals who are developmentally delayed, but your beliefs in terms of alternative means of communication with individuals with developmental delay.
I'm a family physician and the parent of a 12-year-old, mostly nonverbal autistic son as well. And I care for transition-age youth and adults with developmental disabilities, as well as being in general practice. And communication is the foundation of patient safety. It's the foundation of our clinical relationships. So it's absolutely critical, and I appreciate the comments that have come before that even people who are good people and who are doing their best to be helpful can be perpetrators of abuse. And I want to talk about that a little bit today, because I consulted a number of my disabled friends to ask them what I should talk about today, since abuse is such a broad topic. And they all started talking about their experiences with professionals and therapeutic services. And I thought that was very telling. So communication barriers between professionals and people with psychiatric and developmental disabilities can lead to mistreatment. A basic principle of disability rights is nothing about us without us, and people with disabilities need to be at the table when anything that impacts us is being discussed. People with disabilities need to be part of the solution and need to be part of policy discussions and need to be full partners in the care, and I'm glad to see that that is being recognized today. So let me give you some examples of what I'm talking about. A nonverbal patient was walking up to people and punching them in the chest. This was his presentation of heart pain, but instead of getting a workup for heart disease, he got medicated for aggressive behavior. A nonverbal patient couldn't be discharged from the hospital because he wasn't eating. The reason he wasn't eating is because he needs his food cut up for him, but nobody took a history of his functional needs, so a feeding tube was placed instead. A woman with an intellectual disability who uses a wheelchair nearly died of cervical cancer because her doctor didn't ask her about sex. Her doctor assumed she didn't need a pap smear. A child was being sexually abused. Her communication device had vocabulary for food and for activities, but there was no vocabulary in there to protest, to set boundaries, or to communicate that she was being mistreated. Police used a taser on a deaf man because he didn't respond to a verbal command. A man with a psychiatric disability is excluded from a meeting where doctors and family discuss putting him in a residential program. A person with a disability develops pneumonia and feels pressured to choose comfort care instead of treatment because his doctors feel that he's suffered enough and antibiotics are not going to cure his disability. A woman is brought to the psychiatric emergency room where she's separated from her supporter. She gets scared and agitated because she can't communicate and is treated with physical and chemical restraint. A person with a speech impairment and movement disorder goes to the emergency room repeatedly for a serious wound infection, but never gets examined because the emergency room staff assume he's drunk. There are simple things that we could do to prevent these kinds of tragedies, and here are my 10 tips. First, speak directly to patients, not just their supporters, family members, and other professionals. All people communicate. All behavior is communication. It's our job to find out how people communicate best and to support that. Observe carefully, listen, give time, a peaceful environment, and tools to do it. Second tip, presume competence. Assume that there's a good reason why people do what they do and that they have a right to be included in decisions that impact them. That means giving access to information and education as well as support to people to make their own decisions. Third, give people tools to communicate about mistreatment. No matter how profound the disability, all people need a way to communicate when they're being mistreated. Sometimes this skill takes time, training, and creativity to teach. Start early, repeat often. Developing the tools and skills to communicate about mistreatment, boundaries, and choices should begin on the very first day of early intervention. Fourth, teach people to set boundaries and to protest. It isn't our job to make people calm and compliant in the context of unacceptable circumstances. It's to help people maximize their potential and to participate fully. Compliance training is a setup for abuse. Compliance-based behavioral treatments are often cited by self-advocates as some of their most traumatic experiences. Fifth, train families and professionals. People with disabilities aren't the only ones who need training. We need to teach others how to listen and how to respond. Communication is a two-way street. There's an expressive partner and a receptive partner, and the behavior of both is equally important. How we listen is as important as how the communication partners express themselves. But people with disabilities, we need to put people with disabilities in charge of developing this curriculum. 6, take all complaints about mistreatment seriously, investigate them, and protect people from the accused during the process. Even if it's clear that no abuse happened, following the protocol teaches that complaints of abuse lead to appropriate action. 7, give people opportunities to try and fail. That's how we learn, and that should be done when the stakes are low so that people have experience with natural consequences when the stakes are higher. 8, get a history of baseline function. In people with communication challenges, illness tends to present as a change in behavior or function. If we don't know what the person's baseline is, we're not going to recognize when there's going to be a change, and we're going to miss illness. We're going to miss that there's something wrong. We're going to miss that there's something disturbing them. 9th, respect personal boundaries. Offer assistance, but wait for a response and instructions before acting. Treat assistive devices, such as wheelchairs and communication devices, as personal space. There's nothing more frightening than having someone take a hold of your wheelchair, your assistive device, and take control of it. 10, give people access to their chosen advocates and supporters. Many people need support to communicate and to make decisions, and too often we separate people from their support when they need it the most, such as when they're in a crisis or transition. I see this a lot in emergency rooms and a lot when people are entering crisis homes. This leads to errors, violations of autonomy, and misunderstanding, and it can be very dangerous. On this last point, I want to highlight the leadership of the Autistic Self-Advocacy Network. They've drafted a model state legislation that allows people with disabilities to designate a supporter to assist with communication and decision-making. Like a power of attorney for health care, this legislation would enable the advocate to access confidential information in order to provide support and advocacy, but unlike a power of attorney or conservatorship, it doesn't transfer decision-making to another person. It's voluntary, it's less bureaucratic than other solutions. It protects clinicians who respect the patient-supporter relationship in their decisions. And this is really a part of what I think we need in order to improve communication between people with disabilities and professionals and to make self-determination work. I hope California will enact this legislation. There are many resources on the Office of Developmental Primary Care's website that I hope you'll visit, resources that you can give to professionals to help them learn how to communicate better, to learn good exam room etiquette, tools to help people with disabilities to communicate better with their doctors. And so I hope you'll visit the website. It's odpc.ucsf.edu, because safety and communication go hand in hand. Thanks.
Could you please repeat that web address again?
The web address, there are handouts that have it in the back, but it is odpc.ucsf.edu.
Thank you.
Okay, next we're going to have Dr. Sheryll Casuga speak, and one of the things that she's going to talk to are what can someone look for in terms of signs and symptoms if they suspect abuse, and particularly from a layman's perspective. So if you're a person and you suspect possibly a friend or a neighbor may be a victim of abuse, what signs and symptoms can you look for to help determine whether or not abuse is occurring? So Dr. Casuga?
Hi, everyone. I'm really excited to speak in front of all of you today regarding ways we can prevent abuse. I believe that preventing abuse is a community responsibility, so all of us should be vigilant about signs and symptoms of abuse, as well as it's important for us to inform each other on ways we can care for individuals with developmental disabilities and psychiatric disorders. So, three things that I will be talking about today. The first one will be the risk factors and signs and symptoms of abuse, both for children and for adults. The second one, I'll be talking about things that we need to know regarding reporting. And then the third one is just more about proper ways we can disseminate information to prevent abuse. So this is a lot of things to cover, and I'll try my best to provide as much helpful information. Some of the handouts I think are available at the back regarding specific signs and symptoms of abuse. That way you can have something to take with you home, because I'll be talking about a lot of things, and I'll go more towards the breadth of information as opposed to going deeper, and eventually, like later on, you can ask more questions if you want me to go in detail. So I'd like to discuss risk factors for abuse in the psychiatric and developmentally disabled population, because it will be important to provide guidance in prevention strategies and management and treatment plans, not so much as to assume that if someone is falling in this specific situations that they are abusers. So it's not to judge people. So it's prevalent that abuse is happening with the developmentally disabled population and individuals with psychiatric disorders because of misinformation that people have regarding the population. Sometimes they think that individuals that have disorders don't experience pain, they can't decide for themselves. Most of these individuals, they rely on others for care, so that exposes them to situations that increases the risk of abuse. Also, we have to understand that families that have loved ones with developmental disabilities, they are under a lot of stress. They're probably dealing with their own emotions regarding their loved one, and at the same time, they're responsible for their care. They don't get a lot of breaks in their child rearing, and some of them don't have a lot of resources to help them to how to manage taking care of their loved ones with disability. So all of this increases the risk of the individuals with psychiatric disorders or developmental disorders to abuse. And when you compare the research, there's a consensus that individuals with developmental disability and psychiatric disorders are at almost double the risk compared to the general population. So this is something that is really concerning for me, and that's why I wanted to talk about the different signs and symptoms that will help us protect individuals. So for children, it's important for us to recognize that it can occur in any family, and it's important to, like when we see signs, to inquire further regarding the possibility of abuse. So one of the things that we need to look at is the environment that the individual is exposed to. Are there like health risk and extreme like conditions that could cause abuse? We have to look at physical indicators in the child. We have to look at any injuries that the child incurred to see if there are bruises that cannot be explained, or like frequent accidents. Sometimes with individuals with developmental disabilities, they just assume that they're clumsy, or they just assume that they were like harmed and they just like run around all the time. Like individuals that have that are more hyperactive, like children with ADHD, they're always running around, and they just assume that they probably just hurt themselves. But we have to look at and try to get more information as to the causes of frequent accidents in case there's like abuse that has occurred. There are certain burns that we have to inquire further if it looks like cigarette burns or rope burns. These are things that are uncommon for children to obtain, so it's good to inquire further. Facial injuries, internal injuries, and look at the patterns of bruising. Sometimes, individuals that need help with mobility, they get bruises that are commonly in certain areas, like if they're being lifted in their arms, and we don't have to report that right away. We just have to inquire and be more cognizant of the different patterns of bruising that's occurring in our loved ones. So there's also, for neglect, we have to look at malnutrition. We have to look at are they well groomed? Are they appropriately dressed? And for sexual abuse, the common signs and symptoms are bruising in the genital area. Is there discharge that are there are blood stains in their clothing. There are lesions around the mouth, and or lower abdominal pain. So these are the things, the signs and symptoms that we can look at and be kind of on the lookout for. Also, behavioral indicators. Sometimes for children, they are not going to report abuse, so their behavior is more telling. Because also sometimes children don't report because of loyalty, or they feel like they're going to get in trouble if they say something about a caregiver, for instance, that has perpetrated the abuse. So it's good to see if there are any changes in behavior within the child. Not automatically assume that if the child has a change in behavior that it's a product or a consequence of their disability, especially if it's something that just occurred even when everything in the child's life seems stable. Watch out for aggressive behaviors. Watch out for dramatic enactments. If the type of play of the child changes and all of a sudden the play becomes really aggressive or highly sexualized, that's something that is concerning. And watch out if the child has extreme avoidances, doesn't want to go see a particular person or go to a particular place. Children that run away, that's sometimes telling as well. So some of the common behaviors with individuals that have experienced physical abuse, especially with children, they become hostile and they display aggressive behaviors as well as self-destructive behaviors. There's like cutting, banging their head, they break property. And then the ones that have experienced sexual abuse, some of the behavior, it's important to kind of like figure out which one is like a normal sexualized behavior with a young child as opposed to something that is a effect or a sign of symptom of sexual abuse. So some children, they like touching their genitals is kind of like normal, so you don't have to be to suspect sexual abuse right away. But then if it's more like a normal sexualized behavior, usually it's not pervasive. It's something that has occurred like, once in a while, not that often. And if you distract them, they're going to forget about it, especially if you don't draw that much attention to it. But those that have experienced sexual abuse, it's more their behaviors are more intrusive, and they usually have a more sophisticated and they kind of like more, they know more information about sexual behaviors. And whenever a child is displaying sexualized behavior that's coercive, it's highly unlikely that it's normal. So it's good to inquire further when the child is displaying highly sexualized and sophisticated sexualized behavior. Other behaviors do include like acting out behaviors such as substance abuse, eating disorders, and this is common among adolescents. As well as promiscuous behavior, and like a lack of personal boundaries. So these are some of the things that we have to look for with children and adolescents. So for dependent adults and the elderly, it's important to again look at the injuries that they have and are they coming from different stages of healing? Are they injuries? Are they do they have like regular explanations? Because sometimes the caregivers are saying, oh, this happened, but it's something that is unlikely or uncommon. So if that's something that we have to look for, kind of like investigate further. Injuries that have not been well cared for or is hidden, that's something that is concerning. And another thing too is most of the time adults, when they report something, we have to take it seriously, even if they're not as good at explaining what has happened. If they report something, we have to kind of like see what it's about. And they're mostly really good reporters of abuse. So we have to kind of like take their word for, sometimes we have to listen to what they are trying to communicate. We have to be aware of like signs of kind of like medication overdose, like if they're medicated, overly medicated, that's something that is a concern for elder abuse. Look at like broken eyeglasses or not having like proper equipment. Sexual abuse like if they have unexplained STDs, and if they have like, bruises in their like private areas, that's something to inquire about further. And again, like neglect, if they're not receiving proper food, if they're like dehydrated, if their hygiene is bad, or like they have untreated bed sores, those are like really prominent among elderly that have like psychiatric disorders that have been experiencing neglect. So there's like a long list, and I've given you like handout so you can look more and see which one pertains to your particular loved one that you have to kind of like watch out for. So when you've seen the signs and symptoms and you've looked into it and you see that there's a reasonable suspicion that your loved one or someone you know is being abused, now what do we do? And sometimes that's the hardest thing, is to just make the step on like reporting. So the rule of thumb is really if there's a reasonable suspicion of abuse, to report. And if there's unexplained frequent accidents, or if you've witnessed an abuse, it's likely that you have to like report, and you can't just like say like, oh, should I report? Maybe you didn't notice it firsthand. It's more like someone else told you, but if the person's a reliable reporter, that's something that you have to act on. And the most important thing when you're reporting abuse is to document everything. So make sure you include the date and place and the names of the people involved, and keep copies of everything. It's important to write down as soon as like you hear the complaint or you're made aware of an abuse. That way it's fresh in your mind. And you have to report suspected abuse as soon as possible to local law enforcement. So the Child Protective Services is where you report like child abuse, the Adult Protective Services for like dependent adult and elderly abuse. I don't know how many of you are mandated reporters. Definitely doctors, healthcare providers, clinical psychologists. We are mandated reporters, and we're trained to report. We have like we have like exposure to different like training regarding reporting procedures. So if you have like it's better for you to talk to your doctor if you have concerns about abuse, or to like your regional center representative, or if your child is seeing a psychologist, to open up this conversation if you suspect that your loved one has experienced abuse. Make sure you include any special instructions for safety, particularly when contacting the patient, and address special needs. Like we just talk about like the importance of letting people know about the special needs of the individual, even when you're like trying to like report the abuse, because it's important to keep them safe throughout this process. For mandated reporters, it's important to try to include the family and explain to them what's going to happen after the report has started. There's a resource online. I put it on the handouts that I saw. It's for like parents. It's called Keeping Your Child Safe, A Parent's Guide to Abuse Prevention, Detection, and Intervention, and it's available online at www.sc.dd.ca.gov. Do you have to repeat that? That's pretty good. And just like just to briefly talk about other preventative measures. I'm a big believer about information and education. So if we educate our caregivers on how to properly care for individuals with psychiatric disorders and developmental disorders, then we can avoid abuse. Because sometimes, even if, like what was mentioned earlier, like even if we don't intend to, if we're not careful, abuse can happen. So it's all about like giving people as much information. Make sure that you become familiar with signs of abuse. Make sure that before you send like a loved one to a facility, that you talk to the owners of the facility, know who's going to be interacting with your loved one, check out the facility to see how they're caring for individuals that are in place in that facility. I think that just placing your loved one in the care of someone who's not going to take care of them is crucial. So it's important to try to do that extra step. With parents, it's important to take time to learn about the child's behavior, learn about look at their like body to check for bruises when you're like bathing them, or like when they're getting dressed. Be informed of the child's routine to know who they're interacting at their school or at a program that they're in. So you're aware of everyone that's interacting with the child. Teach the child to assert themselves. And it's usually based on the child's developmental level. So like just knowing about how to behave towards a stranger, what is allowed and not allowed in terms of touching. Children can comprehend that and they'll be able to assert themselves in a way. Usually, social stories are helpful for individuals with autism to teach them assertiveness, stranger awareness. It's just like a matter of like taking time to expose them to all these skills that can protect them if we're not there all the time to watch over them. And it's also empowering for someone to learn how to assert themselves and, learn that they can say no to unwanted advances or unwanted touch.
With that have a disability, are there different signs and symptoms that we should be looking for? Because some of the research that suggests that you can identify whether or not someone has been abused at that young of an age. So are there other signs and symptoms or different signs and symptoms that we should be looking for? I'd like to get your thoughts.
I think that there are some, but it's mostly like the same for for children. Some of the things that are more like unique to children that are younger than 2 will be like failure to thrive. Those that that have reactive, like excessive crying. Sometimes it can be like effect of neglect. Those are some of the things that come to mind when it comes to children that are younger than 2. But like I also like that you mentioned that the children that are younger than 2, they're actually, according to research, the ones that are receiving severe abuse, and sometimes it leads to fatalities. So this is a population that really needs to be protected from abuse.
You address mostly community settings. I'm from patient rights. We deal with a lot of institutional. And a lot of the institutions we deal with, because we have a heavy DD population in our jails, our prisons. We have the residential care facilities for children, level 12 and up. We see the seclusion and restraint abuses. You have the juvenile population where we see a lot of abuses. So again, there's a lot of abuse in the institutional settings where it's not this easy. because this is where we as patient rights advocates will call the lawyers or whoever, we'll do all the proper investigation, we'll document it, we'll send it to the state, and nothing's done. And so what usually happens is maybe the staff will leave. Maybe you can check and see if that staff shouldn't have been there in the first place. And there's stories about how sometimes even in the children's facilities where people who were like bouncers from some clubs were hired, because we know that the staff in these facilities are very low paid. They're called child care workers. They have very limited training, and there's a lot of abuse with these with our kids. And I work with the kids. So that's all I wanted to add, because I think people need to know it's not just in your house, it's beyond that. And it's harder for them to report it, even for the adults, because they get worse punishment, especially at Napa or Metro. So just thought I'd bring that out. Thank you.
Yeah, thank you so much for that additional information.
Prisons and jails, that is, and law enforcement in general, the topic of our next seminar. As to other institutions and residential settings, whether it's a residential home, that is happening today. We have someone here from Adult Protective Services who's also going to talk about when the ombudsman may have jurisdiction and the various reporting requirements, and how staff in those residential non-criminal institutional facilities. That'll be after the break, and that is being covered today. It's just the prisons and jails and law enforcement that is being, let me say, part 2 of this seminar. But it is a good question. And we do have someone here from Adult Protective Services and someone else, an attorney from California Advocates for Nursing Home Reform, yet another kind of a facility where abuse happens and neglect happens. And we certainly think it's important, and we'll be addressing that today.
As was mentioned earlier about abuse occurring with the caregivers, I was wondering if you know of any tools, or is there anything else that can be done besides fingerprinting individuals when they're, working in group homes, supported living environments, adult day programs, that can be done to screen out the sexual predators who seem to be drawn to our population. So I was wondering, how can they be more carefully screened?
This is a really interesting question. Anyone wants to jump in, feel free. But I think that it's definitely an important thing to address, having more screening for employees or for people. That way we can screen out sexual predators.
I think people with disabilities usually often know who works best with them and have very good judgment about caregivers and who's going to work well with them. And so if we're doing screening, of course you do the usual things like background checks, but also making sure that people with disabilities, people who are going to receive the care, are very involved in the hiring process and in selecting their staff. Even people with severe communication challenges and intellectual challenges have preferences for staff and are sometimes even more intuitive than other people about who's going to work well with them and who's going to be safe.
I'm Jonah Markowitz. I'm from Berkeley, and we happen to have Easy Does It in our community, which is the emergency attendant services. I have real questions. I don't know how long I can stay because I have a limited seating capacity. But I have real questions about just the basic thing of, and by the way, Easy Does Its purpose is to keep people out of nursing homes, to keep them independent. The question that I have really is how do people in these various institutions who can't really speak very well, ever get a chance to report those things because from my experience being in a nursing home in Berkeley, the staff can't really take care of the person with a disability even normally. So we're getting in. It's important to let folks know we're getting into an arena here where there has to be good training, but even if you train them well, it's like I don't think, my experience is that they don't really like people with disabilities in the nursing home because it's an extra burden. So I hope we can explore today, how best to screen or make a better training, because I know that nursing homes or maybe other institutions have rating systems, and maybe we got to be more aware of the rating systems. So I'm looking for advice on how for communities that don't have the emergency services, how do they handle it?
So listen, that's a very good question. These are problems if they were easy solutions, we would have them, but there are a number of factors that seem to play a role. First of all, careful screening of employees, including criminal background checks, is absolutely mandatory. And if it's not being done, then it needs to be changed. Secondly, it seems quite clear that holding supervisors responsible for behaviors of their employees is crucial. That leads to two things. Number one, training, but also monitoring the behavior of the staff that are working for them. And the third is having unscheduled visits to facilities by skilled personnel who can observe behaviors and observe responses of the individuals in the facilities, not just the employees, but also the people who are living there, so that one can observe without people knowing that someone's showing up. And in current environment, many facilities are now using video monitoring. It's inexpensive and readily available, and so I'm not familiar in California, but in other states they frequently are using high density, that is very common, high density video and auditory monitoring. And when people know they're being monitored, their behavior tends to improve rather dramatically. And so there are a number of things that are taking place that are decreasing the risk, but I think we always have to be vigilant. And the last thing I would remind you is Dr. Kripke's comments that most people with disabilities can tell you what's happening. It's our job to figure out how to help them tell us. It's not that they can't tell us, and we have to help them find the language that they can use to tell us. It's not always spoken words.
Another thing that I would like to add too is, so I work for the regional center, and usually the regional center regulates placements for individuals that have developmental disabilities to make sure that they are providing care, and that they are that all the staff are not infringing on the rights of the individual with disability. And I think that they're very good at really monitoring all these centers, but it's also important for individuals to call and contact the regional center so they can look at the facility to see if they can make changes. And usually what they do is they would visit the facility and talk to the individual and listen to the complaints. And if it's not at par, they usually put sanctions not to place an individual with disability in such nursing care homes that don't provide adequate care and are infringing on the rights of the individual with disability.
I'd also add that, of course, we should take a very hard line on any form of intentional mistreatment, but creating a culture in an organization where there is a non-punitive approach to solving problems and where people feel comfortable bringing up when they've made a mistake or when they've made an error or even when someone's harmed, that when it wasn't intentional, so that we can solve the problem, and not disciplining people who make honest errors in the context of trying to do their jobs to their best ability, so that there's a culture where people will speak up and feel comfortable speaking up and do the right thing when they do see mistreatment.
I'm wondering if there are resources for adults with disabilities. Specifically, I'm thinking of a gentleman who's in his upper 20s who needs sexuality education. I'm a little concerned that he may unintentionally do harm because he doesn't know how to behave sexually.
I put a list of sexuality resources for educating people. One's written by self-advocates and written by professionals on the back table. So there's at least a list of resources, but People to Teach is a resource we need in the community.
So his question is for himself, who is going to listen to him? He has been removed from his home when he was a teen for neglect and abuse. He was put in a group home where he showed up to school with burns and scars. He was placed back at his home. 3 weeks prior to the placement, he was in the hospital for a seizure because no one gave him this medication, where he spent 3 days in the hospital. So this year, when he ends up in the hospital, if he lives through the seizure, who does he talk to? We asked for social workers, we called lawyers, we spoke to everybody. Who does he go to?
So I'm sorry, where is he living now?
He lives at home with his mother. He's in West Contra Costa School District, Contra Costa County.
Okay. And you've talked to Adult Protective Services?
There's been numerous complaints placed, and they were told they would make a note of it, and they would let Regional Center know, and he's not had a Regional Center worker for 2 to 3 years, and we call every 2 to 3 months, and we're told we're on the list.
Yeah, Office of Client Rights advocates are part of disability rights, which patient rights, which we're part of that, and they investigate all the Regional Center complaints. Also, he's in Contra Costa. We no longer have our patient rights office there, but this could be a state complaint. And so if we connect, I could probably connect you with someone in that area, because that's also what patient rights does. We do all the investigations of abuse, of mental health, DD, any person with disabilities. And then we also have the long-term care ombudsman here, who also investigates. We do the board and care homes, the nursing homes, the CTFs, community treatment facilities, anywhere where mental health clients are. So we're out there, and every county has a patient rights advocate, and every county has a long-term care ombudsman. And if you don't get any help through that, then of course you go through the canner. Actually, Tony's here. He can tell you how to file a complaint to take it to the next step. But we're out there. I don't want you to think nobody's out there. We are out there. But what's the problem is the bureaucracy that we have to deal with. And we also deal with community care licensing. And now they've had to change their procedures, because now if you go online under community care licensing, you can find out if this place is licensed and how many violations this facility has had where you think your person's going to go. So it's getting tighter, because it had to get tighter because of the 2 extreme abuse cases that happened in Antioch, and I forget the other one. But we're at a stalemate. We can file any complaint, we can go to the state, and it's the state who lets us down. It's the State Department of Licensing that lets us down. It's the State Department of Social Services that lets us down. Nobody pursues these cases. And you can talk to any advocate of disability rights. There's been report after report of how many of these have not been addressed. And that's the problem. It's the state's problem. They're not doing anything.
Dr. Kripke, you mentioned giving the person who might be having some sort of mental or whatever, maybe they're being 5150, that they have access to a support person wherever they go. And I think it's routine practice that, let's say if the person is having is being 5150'd, or they're being transferred to an emergency psychiatric eval, that the support people aren't allowed to go in, or the parents aren't allowed to go in. And I just wondered, is that one, legal, and two, how do we change that? Or should it be changed? Is that just sort of how it's done?
I share your concern about that and have had the same experience trying to advocate for my patients, where even as a physician, a primary care doctor, advocating for my patients, I wasn't able to access them or to get access for supporters. And in crisis situations, certainly there are good reasons to interview a patient alone, because the supporter may be part of the crisis event. And there is abuse, and that needs to be investigated independently. And sometimes there are people in a person's life who they need to be separated from in order to diffuse the crisis. But I think that there have to be ways for us to include supporters and people who know people, especially people who have communication issues, to have access to their supporters, and I think those policies are very damaging. So I'm not a lawyer, and I don't have any knowledge about how to change those policies, but I agree with you, they need to be changed.
I'm with Adult Protective Services in San Mateo County. One of the issues is whether or not the patient gives consent for anybody to have contact with them. That's an issue.
Yeah, that's where the supported decision-making legislation that I was talking about could be very useful, because then it would be clear. So if we can work together to get that legislation passed, then people can make it clear in advance who those supporters would be.
Right, and the other issue is whether the support person has legal authority to assume that role. Because if a hospital just hears from anybody and they don't have a legal power of attorney or something that authorizes them to act or to consult, they're probably not going to let them in. So we really advocate that people get that done, to get the legal authority done.
But there is a tricky business here. The law says that you can't give information. It doesn't say you can't receive it.
Right.
And so there's no reason why any clinician examining somebody can't take in information that someone's voluntarily contributing, and they
That's
should.
correct.
One of the things that we've noticed in our small office in San Francisco is, we're the ombudsman, is that many individuals who are abused, particularly those with intellectual disabilities, often feel that they were responsible, that they did something wrong, and they feel so enmeshed with the caregivers that they don't want to get the caregivers in trouble. And so the intervention is not just to identify abuse, but the kind of nuances in the response to that abuse, where you develop a strategy to support the person who is the subject of an abuse report, an SOC 341, and tell them that they have not done anything wrong, and hopefully to interview them in a neutral space if they're living in a licensed facility, and to go to them first before going to the regional center case manager or the provider, because both the regional center and the provider are part of a larger system that might be really onerous and perceived by the victim as oppressive. So you really have to reinforce that protection of the victim throughout the course of the investigation, and not necessarily assume that everyone's going to be forthcoming.
Well, I think that there's an important corollary to that. If the sole goal of resolving a problem like this is to punish the perpetrator, you're not going to solve any problems, because what it does is just drives things underground. It's fairly well established when you look at bullying and other things. If you just take the perpetrators and punish them and exclude them, they go to another place and they perpetrate again. That the real trick is, if they've got an illness that requires treatment, if they've got some kind of personality problems, or if they have criminal, then you deal with them in certain ways. But many people who engage in these kinds of behaviors often don't know any better. They're poorly trained. They don't know what they're doing. They may have some impulsivity, whatever. And it's far better to think about this as a problem that has to be managed rather than someone has to be punished. And as a result, The victim often doesn't feel like they're costing someone a job or they've done something wrong, and the perpetrators may actually learn that they can function better in the environment. So we shouldn't just start with punishment. We should try to figure out what the motivation and what the underlying behaviors and the predicate for the behavior was first. Some people are bad people, but many people are not, and to lump them all together is a mistake.